First, I'd like to say thank you, Dr. Morante, for helping me pass the ANCC exam. I did take the Flex crash course. I did the question banks, and the one-on-one was super helpful, especially with the fast facts that were provided. I'd like to thank you, Dr. Morante, for being such a supportive preceptor and mentor throughout my process. Your knowledge and experience and compassion are top-notch, and I'd recommend you to anybody. So again, Dr. Morante, thank you so much for being so supportive, and I am thankful that you were my preceptor, and the classes that you provided were very informative and really helped me to pass the test. So I just wanted to say thank you.
Thank you to Dr. Morante for always being my cheerleader. His live review class was very informative, and the Q banks were hard that they honed my critical thinking skills and strategies for test taking. Dr. Morante has been very supportive, and his wisdom was always on point. Thank you for everything, Dr. Morante and PAS-NP, for helping me pass my ANCC PMHNP certification exam.
I passed! Thank you so much, Pedro Morante, for everything. For your mentorship during all of my clinical hours in my DNP program, for the PASS course that allowed me to have the confidence to excel at the PMHNP ANCC boards the very first try.
Remember your 2-2-1 rule, okay? All those questions that are difficult, sometimes they are non-scored, so don't stress about it. You should be great, and always trust the process, enjoy it. You're gonna be gonna be creating an impact to the community. Remember, it's not just to pass, but also to lead by example, to create an impact to the community. We're gonna celebrate tomorrow because you're gonna be a psych mental health nurse practitioner board certified from the Bay Area, California.
Oh my God.
Congratulations. Did you pass your board today? Wow.
The exam was very tricky. Some of the questions on your review was there. Good luck to the rest.
Yeah.
Okay, guys.
Attended our live class too in LA, right? The one in Koreatown.
Yes, I was in live class.
That was our live class. Congratulations. There you go. Lady Lu from California. Psych Nurse Practitioner Board. So proud of you from being my student to colleague.
Thank you, Dr. Morante.
Now, psych.
You guys,
Board practitioner.
Dr. Morante is really amazing. He lets you be very independent, and you're gonna use a lot, because not a lot of preceptors would allow you to like do hands-on with patients. And you know, with Dr. Morante, it's like one of the best trainings I've ever had, because I learned how to create my care plan, and then just give like, you know, he would give input if you're doing the right thing or not. So that was really good.
Happy Friday! Welcome everyone to Lock It In Live. If you are joining us today, go ahead and put in the comment box where you're joining us today. Welcome to our Lock It In Live. So today our topic will be about dementia. So we're going to be decoding about dementia. We're going to have 5 questions. We're going to break it down, everything, and this is like a free review for everyone. So if you're joining us, go ahead and type on the comment box where you're joining us today. Go ahead and feel free to share us to everyone, for those who are studying for the board exam, for those who are still in school, and for those who are already practicing. So welcome, 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 and thank you for joining us on this wonderful Friday. All right. And then, oh, exciting announcement. So our PASS Review Center is now ANCC accredited provider. So the milestone reflects our commitment to delivering internationally recognized high quality continuing nursing education that empowers nurses to excel in practice and professional growth. So congratulations to the team for Past Review Center. Hi, Jen. Hi, RM Barba. Welcome back. Thank you for joining us today. Go ahead and please share as our community to be able for us to like grow more and continue whatever we're doing right now. This is a free review. Oh, hi Shasta. Welcome from Central Missouri. Dolores, Jan. Thank you for joining us. So feel free to join us. And yes, happy birthday, Dr. Peter Morante. Let's give him like a shout out to our wonderful mentor. All right, we're having more people join us today. For those who are new here, so we have our upcoming live classes for this month. So we have the 4-day weekday PMHNP live review on August 18 to 21 from 9 a.m. to 10 a.m. on Pacific Standard Time. Also the 4-day weekday PMHNP live August 25 to 28, 5:30 p.m. to 6:30 p.m. Pacific Standard Time. And then our monthly 6-hour last minute preparation. If you're taking your board exam, I highly recommend taking this reviews. It's going to be 6 hours high yield, and we're only going to focus on what we think it might come out on the board exam. That will be on August 22nd from 9 a.m. to 3 o'clock p.m. And of course, our every Monday and then every Friday, we do like a free 30-minute session to go over some questions that are high yield that might come out of your board exam. So that will be like around 6 p.m. to 6:30 p.m. every Monday and every Friday every week. So go ahead and join us and share our community to everyone. And for those who haven't, the past review center, we have our PMHNP study collection. We have the master field clinical concept, the psychopharmacology, and then RISE with PASS. I would really recommend RISE with PASS because I was a student before too. So this really helped me prepare for the board exam when I was still studying for the board. So they have really good graphics that would really help you memorize things. There's a lot of things. There's a lot of resources so the resources would only focus on things that are high yield. Remember, the board exam would only test you if you are a safe entry-level nurse practitioner provider, okay? Okay, are you guys ready? Are you ready to answer our questions and break things down? So we'll be talking about a lot about neurocognitive disorders today. All right, let's go ahead. Question number 1. A PMHNP is evaluating 4 patients with major neurocognitive disorders. Which patient most likely has frontotemporal dementia? Okay, your keyword here is frontotemporal dementia. Remember, the part of the brain which is responsible for what? Okay, letter A 78-year-old with progressive short-term memory loss and getting lost while driving. Letter B, a 72-year-old with fluctuating cognition, recurrent visual hallucinations, and Parkinsonism. Letter C, a 56-year-old who demonstrates inappropriate joking, compulsive shopping, overeating sweets, and diminished empathy despite intact memory. Letter D, a 75-year-old with stepwise decline following multiple strokes. Okay, we're talking about your frontotemporal dementia. Remember, your frontotemporal part of your brain is responsible for what? Now, if you know that, you'll be able to answer this question. Okay, somebody said it's letter C. Somebody, okay. Letter C. Anybody else? I think everyone agreed. The answer is letter C, a 56-year-old who demonstrates inappropriate joking, compulsive shopping, overeating, sweets, and diminished empathy. Remember, your frontotemporal part of your brain is responsible for what? Executive functioning, like cognition. What else? Executive decision making, impulsivity. So this patient displays the classic features of behavioral variant frontotemporal dementia. Usually the onset is about 45 to 65 years old. Usually there's like social disinhibition, so inappropriate joking, compulsive behaviors such as shopping. You know what other examples of compulsive behaviors? Hyperorality or overeating sweets. Next, loss of empathy. Memory remains relatively intact early in the disease. Behavioral and personal changes precede memory impairment. So you would notice first what behavioral changes, which is the defining characteristics of frontotemporal dementia. And what do you think is the treatment for frontotemporal dementia? Frontotemporal dementia, which is also known as your Pick's disease. Yes, RM Barbara, you're right. So there is really no disease-modifying medications for this. However, other treatments that could be used is your SSRIs, your citalopram, your sertraline, acetylopram for disinhibition, compulsions, hypersexuality. And if patients are having like signs and symptoms of aggression, we can prescribe your antipsychotics. So would you give your anticholinesterase inhibitors? Usually it's not really helpful. Why? Because it may worsen behavior. Because memory drugs won't really work because memory isn't the initial problem. It's mostly the behavioral changes. All right. Are we good on that? Any questions? No. Okay. All right. Let's go ahead and proceed to the next question. And I think I lost my remote control. All right. So remember your mnemonic for Pick's disease, bad sweet boss, frontotemporal dementia. So imagine your boss suddenly becomes a bad sweet boss. Like all of a sudden, there's like behavioral changes, like behavior changes, apathy because they don't care. They lost empathy. This inhibition. So they're having like inappropriate jokes, like they were making like inappropriate comments. Okay, so sweet reminds you of sweets craving, weird social behavior, empathy loss, excessive eating, and temporal and frontal lobe affected. So if behavior is broken before memory, so you're gonna think frontotemporal dementia. See, I lost my control. Let me try again. Oh, let's go back. Okay, question number 2. A 74-year-old man is brought to the psychiatric clinic by his wife because of progressive cognitive decline over the past year. She reports that some days he is alert and conversational, while on other days he appears confused and unable to follow simple instructions. Over the past several months, he has repeatedly described small children playing in the living room, although no one is really there. On examination, he has a resting tremor, bradykinesia, and a shuffling gait. The primary care provider prescribed haloperidol for agitation, after which the patient became markedly rigid, minimally responsive, and developed worsening confusion. Which diagnosis best explains this patient's presentation? A. Dementia with Lewy body. Letter B. Frontotemporal dementia or Pick's disease. Letter C. Alzheimer's disease. Or letter D. Parkinson disease dementia. Okay, the patient is having confusion. Small children playing in the living room sounds like what? Hallucination, which is a hallmark symptom for what? That is your what? Hallucination. Remember, that will be your dementia with Lewy bodies. So this patient has the core clinical features of dementia with Lewy bodies. So remember, fluctuating cognition, sometimes they're good, sometimes they're bad. And then recurrent, well-formed visual hallucinations like, small children. And then in this case, seeing like small children, although they're not really there. And then spontaneous Parkinsonism, resting tremor like bradykinesia, shuffling gait, and then severe sensitivity to antipsychotics. And that is your dementia with Lewy bodies. So what do you think is the treatment for dementia with Lewy bodies? So the FDA approved treatment for this is your rivastigmine. And then sometimes they would augment with levodopa, especially if there are like dominant motor symptoms. And then please avoid giving dopamine blockers such as your haloperidol, your risperidone, because they worsen Parkinsonism symptoms. In case the patient is diagnosed with Lewy body, when the patient is diagnosed with Lewy body, you're gonna really have to avoid your typical antipsychotics, So if the patient's having like severe agitation, you're gonna prescribe what? Quetiapine or your clozapine. Okay, so Lewy sees before he forgets. The hallmark sign for Lewy body is hallucination. Okay, if the patient sees vivid visual hallucinations early, think dementia with Lewy bodies. All right. Yes, I just mentioned it. The treatment is for your Lewy body dementia is rivastigmine. Okay. Donepezil is also helpful, but the first line treatment is your rivastigmine. And you should avoid typical antipsychotics. High yield, you're going to avoid typical antipsychotics. All right, let's go ahead to question number 3. A 66-year-old man is brought to the emergency department because of rapidly progressive confusion over the past 6 weeks. His wife reports that he was functioning independently until recently but now cannot recognize family members. He has developed frequent involuntary muscle jerks that are triggered by loud noises. On examination, he has ataxia and hyporeflexia. MRI demonstrates hyperintensity in the caudate nucleus and putamen. EEG reveals periodic sharp wave complexes. Which diagnosis is most likely? Letter A, Alzheimer's disease. Letter B, Creutzfeldt-Jakob disease. Letter C, dementia with Lewy bodies. And letter D, Huntington disease. Go ahead and type your answer in the comment box. Anybody, what's your answer? Okay, other people said B. Oh, some people said hey, A. Remember, nucleus and putamen on the MRI. Okay, the answer is letter B, your Creutzfeldt-Jakob disease. So it has the classic triad, okay, based on this case. It has rapidly progressive dementia, myoclonus after triggered by stimuli, ataxia. So supporting findings. MRI basal ganglia, you can see caudate putamen abnormalities. On the EEG, you see periodic sharp wave complexes. It's usually caused by prions, misfolded proteins. So without treatment, CJD almost always fatal, often within 1 year. So do you think there's like treatments? Really, there's none. There's no treatment at all. Instead, you're gonna have supportive care. Most of the time, hospice symptom control, like for anti-epileptics for myoclonus, and then of course pain management. So this is it's a rapid progression of disease. So do not expect for your cholinesterase inhibitors to actually help in this condition. Remember, for your CJD, crazy jerks die, okay? And then there's a rapid progression in the patient's disease condition. So remember, if it's progressed over weeks and there's myoclonus, remember your CJD. Okay, question number 4. A 38-year-old woman is brought to the psychiatric clinic by her husband because of progressive mood and behavioral changes over the past 18 months. She was previously an organized accountant, but has become increasingly impulsive, irritable, and forgetful. She has been treated unsuccessfully for major depressive disorder. During the interview, the PMHNP notices intermittent, purposeless dance-like movements of her hands that the patient seems unaware of. Neurologic examination reveals mild gait instability, and her mother died in her 40s after years of progressive psychiatric symptoms and dementia. So there's history. Which diagnosis best explains this patient's presentation? Letter A, major depressive disorder with psychotic features. Letter B, frontotemporal dementia or Pick's disease. Letter C, Huntington disease. Or letter D, Creutzfeldt-Jakob disease. Remember, this patient has history. Familiar history. Go ahead and type your answer in the comment box. Okay, I think you guys got it right. The answer is letter C. So this patient has the classic features of Huntington disease. So age of onset, usually 30 to 50 years old. Psychiatric symptoms often appear first, like depression, irritability, impulsivity. Chorea or choreography, remember, like dance-like involuntary movements. That's how they're going to describe it, like as if the patient is dancing. So progressive cognitive decline, especially executive function, and then there is autosomal dominant family history. So if you ask the family history, if anybody has some sort of condition, and it was like, yeah, my mom has diagnosed with this condition. So that is your Huntington disease. What do you think are the treatment for your Huntington disease? Really is there's no cure to, just like your CJD. But however, you can use your tetrabenazine or deutetrabenazine for chorea. And then you also have to monitor for suicide risk for patients with Huntington disease. Yeah. So if the patient dances before they forget and parent dance too, it's Huntington disease. That's how you're gonna remember it. So when you're talking about choreography, dance, think Huntington disease. Okay, let's go ahead and do our last question. A 76-year-old woman is brought to the clinic by her daughter because of increasing forgetfulness over the past 4 months. The patient says, I'm getting old. Nothing matters anymore. She reports poor sleep, decreased appetite, loss of interest in gardening, and a 12-pound weight loss. During cognitive testing, she frequently responds, I don't know, and gives up easily despite encouragement. Neurologic examinations normal, and her daughter states that the memory problems seem to begin around the same time as the mood changes. Which diagnosis is most likely? A. Alzheimer's disease. B. Mild neurocognitive disorder. Letter C. Major depressive disorder with cognitive impairment or pseudo dementia. Or letter D. Dementia with Lewy bodies. Your keyword here is I don't know. Yes, the answer is your pseudo dementia. I lost control. So this is a classic sign of pseudo dementia. Your patient will always say like, I don't know. So you would notice like depressed mood, anhedonia, and if you do your cognitive testing, it's pretty much normal. All right. I think everyone got the answer. Sorry, I'm having like technical issues. So sad, but no depression, okay? So the keyword here is the patient would always say, I don't know. That's very classic for pseudo dementia. And when you do your cognitive testing, it's usually normal. Okay. I think that's it for today. So this is a free review. This is like a table that differentiates each of neurocognitive disorders. And then hallmark clues. These are the things that you need to memorize, all right? And easy memory trick. These are your for dementia, Alzheimer's disease, frontotemporal dementia, dementia with Lewy bodies, Parkinson disease, vascular dementia, and Creutzfeldt-Jakob disease. All right. I think that's it for today. So if you haven't signed up on our live classes, go ahead and join us. And thank you guys for joining us today. And I hope I see you on your 6-hour last minute preparation. Thank you. Have a good weekend. Good luck, and you got this, okay? You're gonna pass the board exam. And then next week on Monday, we're gonna be talking about legal principles, which is very important. Bye. Have a good weekend.